In terms of any of the other kind of science that you've seen at this meeting that you think may be of interest to patients?
I think there's several pieces which are interesting. First of all, the understanding the reason that people get CLL, the different groups of CLL by what's becoming clear from all these things we've been talking about is that these CLL cells are driven. They're reacting like normal.
They think they're normal B cells,
and
yes,
they're trying
absolutely.
to react to antigens, to stimulus. And so there's a number of different subgroups of CLL where antigens have been described at this meeting, suggesting that we're starting to show, which groups are reacting to which antigens. And that's not going to help us. We can't,
take away those
antigens can't be removed,
sure.
but it does help us to really understand the different groups of patients. The other major therapeutic sort of change is the ABT-199
sure.
data, which in addition to rituximab. Now, ABT-199, GDC-199 has been very encouraging. It's the drug that encourages the cells to die. And we always felt that this was a drug that would work in combination with other therapies. And what we were very surprised about, I think, was that
it worked so well as a single agent, right?
And so we have the first trial report at this meeting where the drug's been combined with rituximab. And rituximab isn't a very effective agent by itself. But in that trial, about a quarter of the patients in very early follow-up are having eradication of detectable disease, which
sure.
is just unheard of in that group of patients.
Not just CRs, but MRD negative CRs.
And even a small group stopping therapy and
sure.
remaining in remission. So I think our thinking with these novel agents and combinations is, can we give combinations for a short period of time or a shorter period of time, eradicate detectable disease and stop the therapy for at
sure.
least a period of time? And hopefully, if we get the right combinations, can we cure at least some patients with the disease? Of course, that's some distance away still, but I think there's promising signs that we're moving in that direction.
I think for our patients, they'll be aware that the major cost of these new agents is going to be quite a financial burden on health services. And the idea of combining these agents together can probably only happen if we can demonstrate that by doing that combination, you actually decrease the cost overall by having a finite period of time. Is that how you see these combinations going forward?
I mean, absolutely, but I think the main driver for combinations is, cost is really important, and we can't necessarily afford to have patients on therapy for a prolonged period of time. I think the two reasons to combine are, first of all, resistance. So if we target 2 or 3 genes separately with different compounds, resistance
becomes less
much more difficult for the cell to become resistant, for number one. And secondly, patients are better if they're not on treatment.
Yeah.
I mean, I'd rather my patients were treated with a safe therapy that got them into a remission and stop treatment, and then if we have to retreat them in 5 years' time or whatever period later, then that's much better than being on continuous therapy with one drug, relapsing, moving on to the next drug, continuous therapy, and so on. So I think from a eradication of disease, if we're going to really think we can move towards cure, we have to use combinations.
So what we've been seeing at this year's meeting is nothing necessarily brand new, but real consolidation of the underlying science and really important follow-up and identification of subsets of patients behaving in different ways. So I think it remains an extremely exciting time for CLL, as is evident by the rooms overflowing for the CLL sessions yet again. Remains an extremely exciting time in terms of thinking about the treatment of CLL in the future, and we're all looking forward to what we see at next year's meetings.